It is wonderful to be back, and thank you, Dr. Madrazo, for those very kind words. I am honored to be back, and thank you, Lisa. I have not met anybody with more boundless energy than Lisa, who has done more for HCM than anybody I know, whether it's patient empowerment or pushing the clinicians to do more and not taking no for an answer, or always asking why, because sometimes things are done without thought, and it's important to know why, and you pushed us very strong. So I guess I must be really getting old, because Dr. Madrazo asked me to talk about the history of this program, which you are all fortunate to be part of, and my perspective on where the field might be going. But again, Dr. Madrazo, thank you so much for having me here, and you've done a wonderful job, and this morning is just a very brief snapshot of the great things you and your team have done here. So those are my disclosures, but what I want to start by saying is that life is a crazy adventure, and lots of things fall in place, and some things fall out of whack, but in the end, it all works out. And in 2002, Roselle met Lisa Sahlberg at an HA meeting. Roselle, my wife, was here. She'd preceded me here by about a year and a half, and was very interested in HCM, having been at the Mayo Clinic and seen so much HCM. And she said, I didn't know there was an HCM association. She runs into Lisa, and Lisa says, where are you located? And she says, I'm at Hopkins. And she said, well, there used to be a fledgling, not a center of excellence, but people seeing it, but then it sort of died out, and we'd love to restart that. And so that's how the program was launched in about 2004 and became a center of excellence, as Dr. Madrazo mentioned, in 2005. And there's really two people that helped us start: Nancy Grapp, who has retired, and Pat Adams, who was a nurse practitioner, who took almost every single call from all our patients. And I'd say that the crux of our success was the sonographers and nurses of the Echo Lab, especially Joe Wassel, who was the director of sonography when I came, and then Susan Phillip, who helped us expand it substantially. So there were a lot of people. Here are some pictures of folks. Some of them are in the audience, some are not. And then a very large group of researchers, both basic and clinical researchers, who really helped us do so much back then. But it boiled down to maybe three people: Faye Bernardo, our first NP; Norma Flores, our second NP; and June Dameron, who is our coordinator, who some of you, if you were back in the early 2000s, might remember her, but she retired as well. And here are some more recent pictures of Norma Flores before we left. Back then, we had people coming from all over the country, but mainly 8 states. And as the Maryland folks know, how many people come from outside Maryland is a big deal. So the out-of-state population was 40% at Johns Hopkins, which was number 2 next only to neurosurgery. Henry Brem, Ben Carson in neurosurgery had 43% from out of the state, and the HCM clinic was number 2 with 40% of our patients coming from outside of Maryland. And we had significant impact, and I'm glad that Dr. Madrazo has continued that impact. Whether it's diagnostics, we were responsible for almost all the stress echocardiograms, 40% of the cardiac MRI, 20% of very advanced cardiac PET imaging. Procedurally, we did 15% of, we were responsible for 15% of the ICDs. We increased by multiples the septal ablation volume, and we did anywhere from 25 to 35 myectomies a year. Prior to the program being started, it was about 1 to 2 myectomies per year. And then we had complementary programs in pediatrics and genetics, and I see Cindy James here, and very nice to see you. And then radiology and anesthesia, there was significant amounts of research. We had, I think, somewhere in the 50 paper range in the preceding 5 years prior to that. And at the end of it, to Johns Hopkins, this was hugely lucrative. Not only did the volumes climb substantially from 2004 to 2010, and we stopped collecting it then, but there was a lot of care being given. While this is expressed in dollars, there's a lot of lives, there's a lot of great care also offered to our patients back then. So I was disappointed when the program sort of died on the vine, when we were not able to attract Libin Wong to stay, and so I'm really happy that Dr. Madrazo sort of took us off and rescued us and brought this program back to life, and has done such an amazing job. I was just listening today and thinking you did much more than have taken it to really wonderful heights, and I really commend you for all the wonderful work you've done here. So where's the journey start? Lisa probably is the other person in the room who's followed this journey more closely than I have. In the early 1900s, you knew there was this condition where the heart looked maybe thick. They weren't sure what it was. Then in the mid-1900s, you knew what it was, and there was some clinical information flowing through. In the late 1900s, some therapies, mainly beta blockers or calcium blockers, and even disopyramide and other drugs came in. And then in the 2000s, although the genetic basis was already known in the 1900s, in the 2000s there was a huge surge in the understanding of the disease, not just the genetics of the disease, but what we call the biophysical aspects of the disease. And that'll become very important because of everything Dr. Carrick mentioned, was because of this understanding that the disease impacted the fine motors, the molecular motors of the heart that make the heart run and contract and relax. And that resulted in the 2020s of all the wonderful new custom design therapies that Dr. Carrick very nicely summarized. So this is what is happening in the heart. Your heart is beating right now because there's hands pulling on this rope that Dr. Carrick's already mentioned. This is all within the heart cell, and you can see that the myosin heads are pulling on this rope, which is called the actin rope. And in HCM, these ropes or this interaction is overly robust. And what do drugs like mavacamten and aficamten do is you can see these attachments or the hands on the rope. They ask some of these hands to let go, as you can see in that right-hand side cartoon. And that is what results in all these wonderful hemodynamic benefits in the heart that, again, were very nicely summarized by Dr. Carrick. In addition to the drugs that Dr. Carrick mentioned, there are some newer drugs. This is a drug that doesn't have a name. It's called EGG 7500, and it is called a cardiac sarcomere modulator. So the company is not telling us exactly where it acts, but it does not drop the ejection fraction. And Dr. Carrick mentioned how mavacamten and aficamten can reduce the ejection fraction. This drug does not change the ejection fraction. You can see in this one study of 24 hours, the gradient dropped down to normal, both resting and the bearing down gradient. The ejection fraction did not change, and a marker in the blood dropped down as well. And more importantly, Lisa mentioned about patient-reported outcomes, and you can see on the right-hand side there that 90% of the patients had a 10-point improvement in how they felt. We also talked about how this disease is fundamentally a genetic disease, right? When you're conceived, you get a set of genes that come together, and when they come together, if there's a mismatch in one of those codes, you end up having the disease. And one such genetic malformation impacts a protein called the myosin-binding protein C. And what happens in this case, if you have this mutation, is instead of having the normal amount of protein, you only have about 50 or 60% of the protein. And this protein is like a brake in the system, and you've lost your brakes in the setting of hypertrophic cardiomyopathy. So one interesting company took this, a new gene, which is normal, put it in a viral envelope, and by IV delivers into the heart. It goes all over the place, but it actually attaches to the heart cell. It injects that gene into the nucleus of the heart cell and then produces new protein. So now there's hope that you can actually restore the protein levels to normal. So this is genetic therapy that might help even solve the condition at the very outset. So I'd say that there's been large waves of these therapeutic advances. And in summary, I would put this in this diagram, which is you've heard from Dr. Kerr about the myosin inhibitors. Mavacamten and aficamten, one of them is approved, one likely to be approved this December. Then I just talked about the sarcomere modulator, which is it acts on this molecular motor, not known exactly where, but I showed you the data of 24 hours. The same data have persisted at 4 weeks. There's gene therapy that I also talked about, impact in the protein, myosin-binding protein C. And then there's one that I'm not going to talk about where everybody's mitochondria, the power supply of the heart cell, there's some derangement in the power supply of the heart cell, and there's a drug now being tested. The initial studies were highly positive, so they're coming up with a larger study where they will adjust the way the power is harnessed in the heart and allows the heart to function more efficiently. So there's a lot going on, but it takes, as you've seen the entire day, it takes a team of experts. And the reason you are in a great place is because what Dr. Madrazo has now put together, which is an awesome team of experts. You have a HCM expert, you have the sonographers, and I'll show an example of why this team is important. You have geneticists like Dr. James here, interventional electrophysiology, and surgeons like Dr. Gami sitting in the back there. But I'm going to give an example of why it is important to have this team and why it is important to build a team of experts in this particular condition. As Lisa and so many others pointed out, it is not so rare, but it is rare to recognize. So it's not that it's not there, it's just that you're not catching it. And I want to show you an example, and I did not know that this person would be here in the audience, but she will be pleased to know this. HCM is all about imaging and awareness. If you don't know it exists, you can't see it, even if it's staring you in the face. And I'm going to say that this was Jess Dasa, who's sitting in the back. And I still remember sitting in the Blaylock Echo Lab where the sonographers sit right outside all the imaging rooms next to Linda Parker. And I was doing something, and Jess Dasa, who's our sonographer sitting in the back, comes to me and says, "This is a person who was speaking at his nephew's wedding, raising a toast, was very started sweating, lightheaded, and thought he had too much scotch, so decided to stop speaking, sat down, felt even worse in seconds. So tells his son, let's go to the closest ER, which was the Hopkins Bayview emergency room. He goes there, gets transferred to this hospital here, has an angiogram because his EKG looked like a heart attack. He has an angiogram, didn't find a lot of stuff, but they found something really small in a small artery, so they decided to balloon it. And then the next day they said, we need an echocardiogram. And Jess Dasa comes to me and says, this does not look like a heart attack. It looks more like HCM. And it's not the garden variety HCM. And for those in the audience, I don't know if my mark will come up, but right there you see that the heart is thickened in the middle. She did a cross-sectional cut, and you see the heart is obliterating the cavity. And then she goes up higher, and you see this big blob in the middle that looks like a clot, and it is a clot. And then you see that she's done this fantastic image of what we call the apex, and you see that there's a clot up here. This part is not moving very well, and then there's a high pressure jet there. And remember, the normal is 10 millimeters, and this went up to 110 millimeters, so very high jet. This is the MRI that also shows a thickened heart, a thinned out tip that Dr. Carrick spoke about, this apical variety, and a clot sitting in that tip. All dangerous conditions. Of course, this person got an ICD because he just had a cardiac arrest. So by the way, when he went to the emergency room at Bayview, he was in monomorphic ventricular tachycardia. So in sort of a cardiac arrest, they had to shock him out of it. So he had complex surgery. One, Dr. Gami mentioned how they go through the aorta, and they took a little bit of the bulk of the muscle away from there, but they had to go back in through the tip of the heart. They had to excise out that scarred out tip. They had to extricate the clot. They had to do even more debulking of the muscle, and then they took a patch and put it there to buttress or augment that tip. And this person got discharged in about 2 weeks or so, or 3 weeks. He was back on his boat on the Chesapeake Bay, and I think has done well since then. So team approach, very important, and the team here is just fantastic, and you've just seen snapshots and small portions of their clinical acumen and excellence today. Going back to the history, a lot of people contributed to our success back then, and I'm going to just let you dwell on the number of people, the number of specialties, and many of them are still here and operative right here. So I'll end by saying that since the 1900s to the 2020s, there have been ripples of advances. Things have rippled. You've heard about the genetics of HCM, drugs, imaging, all that good stuff. ICDs, all this has helped, but it's not been transformative. But I'll say in the 2020s, what has happened is a rogue wave, or these monster waves of advances that are happening almost on a yearly basis. I think, Lisa, you would agree with me. Almost every 2 years, you're hearing of a new company, a new drug, or a new approach, and I'm not going to go into detail in the interest of time, but a lot has been happening. HCM is a very important condition because 80% of the people will be fine, but you don't know who those 80% are. So you need to find every one of them to find the 9 or 10% who are going to have severe complications. Almost all of them are preventable. No one needs to die, and Lisa knows from personal experience. Nobody needs to die from HCM in today's day and age. And recognition is important. Treatment at a center like this is very important. This is a momentous time where some of the advances, even in the last 5 or 6 years, are making transformative impact on quality of life of people and the longevity of life of those people with HCM and their families. The partnership with HCMA has been amazing, not just for us, having been here in the early 2000s on the West Coast, but for 57 other centers or 56 other centers. Congratulations, that's just amazing. And that's what it took. It took that flame to light so many candles all across the country and in the world. Lisa's now speaking internationally, so she's been very instrumental, certainly in the formation of the HCM Center here, and I think the reformation in helping Jose and his team garner such success. And lastly, many congratulations to Dr. Madrazo. This was a legacy we thought we'd lost, and thanks to you, this lives on and is thriving and flourishing so well, thanks to your vision. Dr. Madrazo is a sportsman. Well, what do you know about sportsmen? They are dedicated, they're disciplined, they are very thoughtful, and they like to win. And I think you have a winning program here thanks to all that. So thank you for having me here. I could not be more honored to come back here. This feels like home because this is where we started. The HCM program was the first program I ever started in my career. I had just come out of the Mayo Clinic 3 years after fellowship. And thanks to Lisa and my wife, I decided to start this program. And it is just so heartening to see all of you here, but to see the amazing work that Dr. Madrazo, Dr. Carrick, and the rest of his colleagues have garnered here. So thank you for having me here, Dr. Madrazo and Lisa, and I hope you have a great rest of your program today. Thank you.